Hello, this is Dr. Scott Werden, the TOS guy from beautiful downtown Sunnyvale in California near the Apple campus. Welcome to our first talk of 2023. We are really happy to get started on the new year. What we've decided to do is to review and summarize some of the great things we did with our partners and physicians and other providers around the country in 2022. So without wasting any more time, let's take a look at some interesting clips that you've seen in the past year, and I hope they bring back some good memories. First, Dr. Rob Hagan. Think different. Rob handles things in a different way than a lot of surgeons you may have heard from, and here's a great example.
And for me, this is just an offshoot. This is why I love having these discussions with you. I've also thought that hold the shoulder forward and down to relieve some of the symptoms. By releasing that, you're allowing that shoulder to come back up into a better position. You're also elevating the clavicle, right, which opens that costoclavicular space. That in conjunction with releasing the scalings off that first rib, and I'm a believer that first rib drops once you release the scalings off of it, right? So the composite of raising that clavicle and dropping the first rib sometimes converts people from, even if they're in a gray zone of maybe they need a first rib out, but we've opened up the space. I think that's meaningful.
So that's really great. We hear from Rob why he considers not removing the first rib in a lot of patients that he performs surgery on for TOS, and he's got a great success rate. And we definitely encourage people to reach out to Rob to learn more. Next, we had a lot of information we received and very good explanations from Steve Talikowski, who carries on the Peter Edgelow method and has refined it over a lot of time. It's now called the INVEST program. And here's Steve describing some of the basics.
Here's the typical course of treatment for that patient using the INVEST program. So I tell patients you're going to have up to 12 visits of PT. It could be more, but by 12 visits or maybe even 6 visits, we expect to see improvement or we need to move on to something else. The important part here is those 12 visits can happen over 4 to 6 months. So why I say that is I just want people to have a kind of a realistic expectation as to how long it's going to take. And I don't mean to get better, but to get to the later phase of the program, which I'm going to talk about in a few minutes. The first goal of the INVEST program is to calm down the nervous system. It is not to stretch and strengthen or to change the position of the scapula through scapular strengthening exercises, nerve glides. This is only based, though, on symptom response. The patients I see typically have gone to a therapist, they've done stretches and nerve glides, and they've gotten worse. That's why they're seeing me. If you're doing nerve glides and scapular and rotator cuff strengthening and you're feeling better, that's amazing. Keep doing it. But what I'm trying to say is if you feel worse, don't feel like something is wrong with you. It's not the right time for these exercises. We also include core exercises related to improve mostly for posture and spinal and rib positioning. So we're not talking about sit-ups and planks. People say, I got to do planks. I want to get my core stronger. We're not ready for planks. This is more activating the core muscles in the neck, those deep flexor, those longus colli muscles, your abdominal muscles to kind of help improve your posture. We need aerobic exercise daily to help improve endurance. The other part is if you're walking, you're not sitting. And we have to make postural training and changes to the body, but with this expectation of going slowly. the person has a lot of stiffness in their thoracic spines, in their low back. We can't change that today or tomorrow. We have to calm things down first.
So many of you may have heard of the edge-low technique before, and Steve is very popular for carrying on this tradition. And that's interesting. Dr. Hagen, can you hear me?
How we doing? Can you hear me?
Good to see you. Did you just miss the highlight of our show?
What's that?
You must have missed the highlight. I started out the whole thing by playing a clip from our discussion last year. We were talking about the clavipectoral fascia, and you were talking about how you got success with people without removing the first rib.
Yes. Can you hear me?
I can.
Good. Awesome. Yeah. No, well, Herb had sent me a link today and said that you were going to be doing some recap and wanted me to jump on and surprise you, and I was more than honored to do so.
Thank you. That's great to see you. You're at Neuropax. You want to tell people a little bit about your practice, and we can definitely help give you a, what do they call it? When you're bumping a movie and you show up on Johnny Carson. I don't think this is Johnny Carson.
Yeah, well, as you know, I'm a plastic surgeon by training. I focus nearly all of my practice, 95% is on peripheral nerve. Part of that is treating neurogenic thoracic outlet syndrome, which is a nerve problem. So we've been doing predominantly nerve for the last 15 to 17 years, and have made a lot of strides and improvements on how we approach a lot of different peripheral nerve problems, including neurogenic thoracic outlet.
Right. And you've taken a very customized approach to each patient. So I often tell patients, especially the ones who say, I don't want my first rib out, you're one of the best people to call about that. So thanks for showing up. I really appreciate it, and good to see you.
Thank you. My honor. It's so fun. I mean, every opportunity I have to discuss this problem with you is a great opportunity.
The same for me, buddy. It's really, really good to be able to move things forward and have these open discussions. Thanks.
Awesome.
All right. So I'm going back to our slideshow here. Let me share screen again. And so next is about TOS teamwork. And we often say this, that TOS is not low-hanging fruit. And we have found the community around the country our best success with TOS patients by having different specialists involved. Here's an example with myself and Dr. Art Jenkins in New York discussing a case in some detail and using different technology.
This is a patient who's she's in her 50s, and she's had pain for 40 years. Mostly in the right, almost exclusively in the right, with severe weakness. I mean, the right hand is significantly weaker than the left, to the point where she can't even make a C, let alone an O with her right hand. She feels faint, like she actually gets like dizzy when she lifts her arms for 45 seconds. Not just weak, but faint. And she has pain that's distributed not in the classic costoclavicular compression TOS pattern. It's more of the hand than we usually see. And she actually was primarily arm pain, and 3 months ago she started having neck pain as well. So we looked at her spinal imaging, and lo and behold, she's also got cervical disc herniation. So now we've got to be thinking, how much of this is radiculopathy? How much of this is TOS? And so on top of that, she has this condition called congenital stenosis, where her spinal canal is a little smaller than normal at baseline. So when you throw these disc herniations in, it's even more symptomatic because they just have less room to accommodate.
As as Art mentioned, one of the things we want to rule out is spinal disease. So our study, the NeoVista MRI, always includes the cervical spine. These are two images from the right side that again show the disc bulges, the narrowing of the neural foramina, the side holes, which each allow one of the nerve roots to come out. This is from her right side. She's got a very broad insertion of the anterior scalene muscle, and she's got something pushing the artery, that black spot in the middle, forward and bulging that anterior scalene muscle. That is a cervical rib. And then here is a picture of the cervical rib, nicely shown on MRI. Now, with the arms elevated, she's got pretty advanced narrowing of the costoclavicular interval. In this case, the brachial plexus is right in the middle there. And when we look on her left side, she has hypertrophy and broad insertions of both anterior and middle scalene muscles. This is a soft narrowing of the scalene triangle, with again a muscular sling lifting up the neurovascular bundle. And she's got narrowing between the rib and the collarbone on the left side. But because she doesn't have a left-sided cervical rib, she's got a little more space to play with on this side. Again, we're pointing out the brachial plexus between those two bones.
This is one of the things that I'll do sometimes is I'll get a CAT scan to look at bony anomalies. This is what three-dimensional reconstruction of this CAT scan looks like. You can see that the one side it has this longer spike. It's almost like a fang coming off of the spine that the other side doesn't have anywhere near that size of a process there. And so this is the cervical rib over here.
So again, it's a wonderful thing to have a team of experts, people who have different viewpoints and different levels of experience, and obviously different fields of specialization for this very challenging disease. Here's yet another example. We had a panel discussion with Dr. Priyanka Ghosh in the San Francisco area, Dr. Tracy Newkirk, who's pretty famous in the field, and again, Dr. Jenkins and myself. Great. I'm going to segue into our next question, which is, I've had multiple physicians tell me that my negative EMG indicates that I don't have TOS. And another question from a different source, what is the single best diagnostic tool for TOS? Priyanka, how much experience do you have with EMGs? And what tests do you consider helpful for the diagnosis?
So I'm anesthesia trained, so I don't do EMGs. I have trained a lot and watching them and I read them a lot. I think EMGs are probably less useful for TOS. I feel they could be a tool, but I think the most useful things to diagnose it are really clinical history, physical exam, provocative maneuvers, and what Dr. Newkirk said, things that relieve it. And then honestly, the good radiologic studies. So the MRI, MRA, MRV that Dr. Werden is known for, not only is it great because it's dynamic and there's multiple things looked at, it's also great because he is an expert in reading things for thoracic outlet and looking for it. So I would say not just a good radiologic study, but an excellent radiologist who reads it is probably the best diagnostic tool in addition to history and physical exam if I had to pick my favorite.
You really make a compelling argument. I don't even know how to argue with that. Tracy, what about you?
Well, let's have Art tell us about his electrodiagnostic studies without the initials, by the way. Art, don't you dare talk about SSEP. Talk about words that we know as to why EMG can be useful if and only if you do it under the right circumstance.
Yeah,
You got it, Art. Go.
So the electromyography, or AKA EMG, is probably the least useful tool in terms of identifying symptomatic thoracic outlet syndrome in IMHO, in my humble opinion, because the EMGs are never positive unless you already have atrophy. And if you have atrophy, you'll see that when you examine the patient. You say, hey, they got a divot in their hand, or they've got a divot in their arm in a distribution that's relevant. They know they've got a weak hand. They know that they have this. Essentially any reversible condition, any condition that comes on and off is going to be negative on the EMGs. So it's a useless tool for TOS. It is useful for ruling out other diagnoses such as cervical radiculopathy or nerve entrapment elsewhere in the arm or hand. But by the same token, it as TOS goes, it's really not terribly useful. I know that Dr. Newkirk is leading me into an area of interest that is more on the research side than on the clinical side right now. But we know that there are other electrodiagnostic tests that can be positive in TOS, in positional situations. And somatosensory evoked potentials and motor evoked potentials have been shown by 2 different studies to have potential benefit for diagnosing thoracic outlet syndrome. However, they are both somewhat uncomfortable to perform on awake patients. And so they're, right now we're working on trying to come up with a better way of doing that as a pre-operative, pre-evaluation diagnostic test that has sensitivity and specificity, that it's sensitive, it picks up the cases, and that it's specific, you don't have a lot of false positives.
And yes, we're lucky to have people doing research like this and to be able to share it with everybody else. It's great for patients in the long run. All right, I'm going to change direction a little bit. We had our first talk presented by Dr. Vernon Williams, a highly specialized and respected sports neurologist at Cedars-Sinai in Los Angeles. And during his talk about TOS in athletes, he presented his paradigm for separating out TOS into at least 2 different categories.
One of the ways to think about thoracic outlet syndrome and brachial plexus injuries is to categorize them based on how they present. And we can do that and kind of discretely describe them with respect to the onset. Is there a sudden or a gradual insidious onset? What part of the brachial plexus is affected? The upper trunk versus the lower trunk. And you can see the chart there. And it turns out that when we talk about stingers, that's something we often see in football, in hockey, in wrestling. When there's a sudden onset of injury, it's more likely for the upper trunk to be affected. It's normally a nerve issue. And those tend to be self-limited. People will come in and say, yeah, this happened and I had symptoms for 10 minutes or 15 minutes or 12 minutes, and then it kind of gradually went away. That's what happens most of the time, not always, most of the time. As compared to what we might call thoracic outlet syndrome rather than a stinger, meaning there's a more gradual insidious onset. More often, the lower trunk of the brachial plexus is affected. And these individuals will often have neurovascular symptoms. Some symptoms attributable to nerves, other symptoms attributable to blood vessels. It can be arteries or veins. They may have more swelling or temperature differences or discoloration or those kind of vascular features. And we tend to see these kinds of injuries in other kinds of sports. Overhead sports, like baseball players who are throwing and stressing the extremity that way. Sometimes with fast pitch underhand baseball. Swimmers. These are individuals where people may have a more gradual onset, and these symptoms tend not to just go away on their own. They more likely require some kind of intervention.
And again, this is an incredibly intelligent, practiced man who does a great job with all kinds of neuropathies. So if you're on the West Coast, he's a great resource for TOS and a really good guy too. We're lucky to know him. I did a brief talk about, as you can see here, TOS in modern life. So let's look at some of the ergonomic issues with laptop computers. Number 1, keyboard spacing. Keys are almost invariably smaller and closer together. And oftentimes you need to use 2 hands to hold modifier keys because all the keys aren't there. Most laptops of any reasonably small and portable size don't have a numeric keypad either. So reaching to the top row for function keys or number keys is harder. Secondly, monitor placement. Monitor cannot be up by your eyes if you want your hands in good position. And if you want your hands in good position, well, the monitor is just down right where your knuckles are. It's not good for you. You can't get your neck and your arms and your shoulders into the right position no matter what you do. The monitor size is almost always smaller than a desktop monitor. That's a problem for a number of reasons. You have to get closer to it. So like me, you might lean into it to see the smaller things. And finally, the size of the control surface. You don't have a mouse that you run over a big mouse pad. You have a tiny little trackpad. Maybe like on the ThinkPad, the IBM computers, you have a little red plastic thing in the middle you can move. But they're all very small, and so it forces you into a position just to use the control surface or to use the keys or to look at the monitor. That is not ergonomic. And I'll just add, I do a lot of my work on laptops, and I'm constantly aware that I'm not, not in a great position. So people who do have TOS, all our patients, I do encourage them to take a break or find novel solutions like using a separate keyboard along with their laptop monitor. All right, so we had a patient. We had several patients on during 2022, but this guy is really unique. He has a great story, and I hope you remember it. They have a great website telling his whole story in great detail. Anyway, this is a story about overcoming adversity. Jake is a high-level elite swimmer in college, and I'm going to let him tell you a little bit about his story.
My mind is in two different places. I was racing, and I saw the guy flip ahead of me, and I was like, okay, I can run him down. And now, in my other part of my mind, I saw in my head a memory from my second surgery where I was wheeled out of the hospital room pre-op, and my dad got to go back into surgery with me, which was something that I needed because he knew everything that was going on because he was a physician. And he was like, this is what they're going to do. This is where you're going. Oh, this guy, he's great at what he's doing. You're going to be just fine. And that's something that I needed to hear in that process. But I saw going down the hallway, looking back, my mom just standing there crying. And that memory for me is what gives me my drive at the end of those races, is seeing her and knowing this was the pain that we all went through. And so I flipped there, and I was about 1.2 seconds behind the guy, and I ran him down and I out-touched him, and I was able to win my first junior national championship. I remember after I went up on the podium, like I was so excited. I ran around the pool deck to find my mom. And I just remember, like, I saw her down at the end of the pool, and I just sprinted to her and gave her the biggest hug. Because once again, it was another moment where all that hard work, all that pain had finally paid off. And it was something that I never thought I'd be able to do. And it's something I was so blessed to be able to do.
That's a great story to watch. We love seeing that. Jake is such a good. My producer is surprising me today. Jake, how are you?
I'm good. I'm doing well. How are you doing?
Great. I love that Alabama shirt.
Thank you.
And, when I was preparing this talk and I looked through your, through the time that we spent together here, it was really inspiring.
Thank you. Thank you. It's been quite a journey, and I hope that anybody out there listening can take something away from my story, and that it can help them in some sort of way.
How are you doing now?
I'm doing great. I'm about 2 weeks out from the SEC championships out at Texas A&M. So been preparing for those. We went through the senior day ceremonies earlier this month in a dual meet against Texas and Ohio State. School's going well, finishing up this semester, hopefully strong. But yeah, things are going great.
That is great to hear. What are your plans after school?
So I will be finishing up my degree next fall. I have one more class to take, and then I'll be applying to dental school this summer.
Nice. That is great. How are your parents doing?
They're doing well. I believe they actually are tuned in right now. So if you're there, hi, Mom and Dad. I miss you guys. I love you guys. I'm thankful for your guys' support through this whole journey. I wouldn't be where I am without you guys and your support and willingness to listen to me during the hard times. And you gave me the kick in the butt sometimes when I needed it. And I'm always appreciative of everything you guys have done for me. And I wouldn't be here. I wouldn't have made it through as far as I have with TOS without you guys by my side and supporting me.
Well, as a parent, I can only say I hope I do half as good a job raising my kids as your parents did. Thanks. Really appreciate you visiting us.
Of course, of course.
And keep us in the loop, Jake. We want to hear how you do. All right, I'm going to go on to our next story here. And this was, no surprise, Dr. James Markham, who has an amazing passion for the endothelium. He's a cardiologist and he knows a ton about a lot of things. Anyway, his talk was really difficult to encapsulate in a short thing because it was just filled with science and passion. Here's a small piece.
So the endothelium is a one cell thick that goes around all of these tubes that go out throughout the body. So the function of the endothelium, both the endothelium that goes around arteries and veins, it's four big functions. One is it's a highway. So that's one important function of the endothelium. When the endothelium doesn't work, we don't move oxygen, we don't move waste, we don't move energy. So that's very important, and it affects not only the endothelium of the heart, but the endothelium that goes out to the arms throughout the body. It's very important in hemostasis. So if you have blood clots and things that damages this highway, the endothelium gets clogged up. The third function of the endothelium is it affects the immune system. So you've heard the word inflammation, white blood cells. Well, when this endothelium, this highway is inflamed, bad things happen. But now let's get back to the damage from thoracic outlet syndrome. Well, the damage to thoracic outlet, some of these others are indirect damages. But when we have thoracic outlet syndrome, specifically, the blood vessels are usually damaged secondary to trauma. We have the trauma of an outside not being able to move blood and blood vessels through a small opening. Some of that trauma is by repetitive activities. Some of it's genetically induced by an extra rib. Some of it's genetically induced by a lot of pectoral muscles being so big that it traumatizes the blood vessel that has a limited space genetically to move through. And likewise, it damages the neurovascular bundles as well. Well, the nerves are involved in all of this because guess what? The endothelium and the arterial system in the thoracic outlet syndrome supplies and takes care of the nerves.
That's right. And we've been learning a lot more about how venous congestion or arterial disease can affect even the small nerves that make up the brachial plexus. Dr. Markham's incredibly knowledgeable, very passionate, and also a really great speaker. And we were really pleased to have him on our show. I did a quick talk on the rarity of TOS because a lot of our patients hear that. You can't have TOS. It's rare. Or you can't have TOS. It's disputed. When I dug into the medical literature, I didn't find that it was really rare. As a matter of fact, I didn't find that it was known at all how common it was. What is the incidence of TOS? How many people show up every year with TOS? Well, let's take a look. I went through the medical literature. And I tried to track down exactly how people had figured out how common TOS is throughout the country mostly, but there are a few other countries thrown in the medical literature. So starting with Lee, in a book that I contributed to in 2013, Jason Lee wrote down that the incidence of TOS is between 3 and 80 patients per 1,000 population. That would be a lot. That would be 3,000 to 80,000 per million population, which actually seems rather high. Well, he had gotten this information from a paper written by Huang in 2004. What did Huang say in 2004? Well, he said the 3 to 80 per 1,000 population, and he had gotten that from two references, David Roos and Asa Wilborn in 1990. So I hadn't gotten to the bottom of it yet. I pulled up those papers and read through those. So in 1990, Roos wrote a paper with no mention at all of the incidence, no numbers. And I found Wilborn in 1990. He didn't have an estimate of incidence either, although he did, as we'll look at later, come up with the concept of true neurogenic TOS versus disputed neurogenic TOS, something I have great interest in for a number of reasons. All right, let's go through the medical literature again. I found another reference by Tsao in 2013. What he said was that true neurogenic thoracic outlet syndrome, we'll discuss what that is later, has an estimated incidence of only 1 person per million population. Now that's really low. And he had gotten this from a surgeon at LSU, I believe, named Gillat in 1970. And then Wilborn in 1988 also said there was an estimated incidence of one patient with true neurogenic TOS per 1 million people in the population. And he referenced Gillat in 1970. So let's go find Gillat in 1970. An article called Wasting of the Hand Associated with a Cervical Rib or Band. He provided no estimate of the incidence. So right now I've got a very high number and I got a very low number. And none of these have demonstrated any methodology about how they calculated the incidence. But it seems like the medical literature is just repeating what others have said without verifying. Yeah, so this was of interest to me because we really don't know how common TOS is. So when somebody says to you, the patient, yeah, it's rare, or you couldn't have it, or I've never seen it, that's probably not true. My personal feeling is whatever the starting point, we're increasing the number of patients with TOS due to more recreational activity like rock climbing, as well as people using devices, personal devices, and computers, not just laptops I mentioned before, but phones and tablets, etc. So hopefully we'll get to the bottom of it. Let's go back, see what else we had in 2022. All right, so Art Jenkins, who is a great contributor to our channel, another talk he gave was how to find a TOS specialist. Very long talk, but we started out talking about internists, the docs who are usually responsible for adult medicine. So Art, in your experience, when you have a patient referred to you from an internal medicine doc, what's their general level of expertise on TOS?
Oh, I mean, I think TOS is such an, as you mentioned earlier, it's like an orphan condition. Most people, most generalists don't know much. And I'm delighted when I see one that even recognizes the name and tries to put it together with a clinical syndrome. You know, as you said, they have to know some about a lot of things. And so, you know, I'm always delighted to get a consult for TOS. And then, but like, you know, like most of my patients, if they're coming from a generalist background, I'm going to have to do a very deep dive to make sure that they're not, you know, presenting with one of the many different clinical syndromes that overlap with TOS. So, and I think that's going to become a little bit of the recurring theme, I think, of tonight's talk, is that I'm going to be deferring back to the concept of you need to make sure that whoever you go to has an open mind, doesn't get pigeonholed, and, you know, thinks about all the different things and does and treats many different things. So going to your primary doctor, if you think you might have TOS, or even if you don't know you have TOS, you just got arm pain, and problems at your arm and shoulder area, and you're like, well, what is this? I don't know. Let me go to somebody who knows what they're talking about a little better than I do. And that's the process of winnowing your way down into getting the right diagnosis, and getting it treated after that.
So Art's points are really well taken. Many people with TOS will first be seen by their primary care doc, sometimes by a physical therapist who makes a suggestion. And that primary care doc can often be your quarterback, the person who takes care of collating and coordinating all the different specialists that may be involved in your care. So it's a valuable person to work with, even if they don't know all the details about TOS. I will say this, I'm encouraged this past year of 2022, we found a lot of great people to work with, really smart people. It's overwhelming sometimes to have these people just come up with this great concepts that they've visualized and worked with over the years. So we're thankful for that. And as the picture here shows, working as a team is really the pathway to helping TOS patients. So that's our review of 2022. And I think now we have time for some questions, hopefully.
Hey, Doc Werden.
Yes,
I'm going to add Dr. Hagen back into the stream because I know that you've been struggling with a cold. And so maybe he can help with a few of the questions.
He can help because he's got a better brain than I do too.
Well, okay.
Hey, thanks for sticking around. That's great. All
Am I
right.
back in? Great.
There, I can see, actually, I can hear you, but I don't see you moving at the same speed. All right.
That's interesting.
So can you see the questions showing up at the bottom, Rob?
Not as of yet. I can see some of the comments.
Okay. That's what we use for questions, our comment section. So, excuse me, Tammy says, I have scalenus anterior and medial strain, grade 2 strain of the left pec major muscle. I don't know if you mean pec minor or pec major. Clarify for us. So she says these this scalene anterior and medial muscles are pressing on her brachial plexus at C5-6. Can this be an indicator of TOS? And she had a car accident 2.5 years ago. She says she has pain deep in the chest and armpit. My MRI for TOS did not show much at all. Okay, let me just start out by this, Tammy. We don't give specific medical advice. We're going to talk about this generally. I hope you understand. If you reach out to us through the website, tosmri.com, we're glad to get more personal and help you in private. But Rob, she's had an MRI. I don't think I've seen this. Her name is not familiar to me. It looks like she has had an ultrasound done too. And she's waiting to see a neurologist. So someone comes to you, they say some imaging shows their scalene muscles are strained, their pec muscle, minor or major, is strained, and C5 and C6 are involved. What are you going to do with that information next?
Well, all those things, you know, with her history of a motor vehicle accident or possible whiplash, in the context of those is really important, right? You know, when, you know, if she presents and the symptoms, the distribution of her symptoms, the focused physical examination, all of those components are leading us again towards a working diagnosis of neurogenic TOS. Then you proceed on, right? And she already has the benefit of, as you said, having the MRI. Another buzzword that she talked about was axillary pain, which can be the pec minor involvement or even the long thoracic involvement as well.
Now, you've told me before that when you do surgery, you find a lot of variability in the long thoracic nerve. Is that correct?
We do. You know, as I shared before, early on, we didn't pay as much attention to the dorsal scapular nerve, the long thoracic nerve, or the suprascapular nerve. And patients would come back and say, gosh, my arm feels a whole lot better, but I still have pain in the posterior shoulder and even radiating the axilla. When we started looking at that closer, those distributions of pain matched up with those three kind of what we might say is the accessory nerves of the scalene triangle. And as we begin to pay more attention to those and neuralize them out of the middle scalene itself, those types of pains got fewer and far between, and we got better and better outcomes.
And for people who don't know, the peripheral nerve surgeons like Dr. Hagen are expert at these tiny peripheral nerves and really understanding the anatomy and variability and dissecting them out. It's not like using a chainsaw, right? It's very, very detailed.
Yes.
I don't mean to be callous about it. It's just different, surgery techniques. Different fields of surgeons take different approaches, but peripheral nerve surgeons are incredibly detailed from my experience.
And the same principles that we utilize throughout the body, whether it's in the head, the neck, or the lower extremity, we apply them to the different areas, particularly with the neurogenic thoracic outlet, and just always looking, how do we improve our outcomes? How do we individualize each surgical approach? How do we stratify care better and better to every patient?
It's awesome. Tammy, I suggest reach out to us through the website. We can get you connected with experts like Dr. Hagen and hopefully help you. Thank you for the questions. All right.
Questions. This is great.
Tammy is asking a different question. If what I have is a brachial plexus injury and not TOS, what can be done to fix it? Do you want to comment on kind of the difference between classic TOS and a direct brachial plexus injury?
Yeah, I'd be happy to. There's a spectrum of brachial plexus injuries. And TOS tends to be kind of more on the, believe it or not, on the mild side. There's not typically an intrinsic injury to the nerve or the brachial plexus. It tends to be more an extrinsic compression, irritation, tethering. Now, a plexopathy is then something that actually stretches the nerve, damages the nerve intrinsically, and that will usually be caught on a electrodiagnostic study. And then even a more severe injury would be something like where somebody mentioned the C5 and 6. I have a patient right now that had a C5 and 6 avulsion. It was a bad whiplash injury where both of the nerve roots were pulled away from the spinal cord. That's not going to be repairable. That can't be repaired with a decompression, for which we do utilize as treatment for the neurogenic thoracic outlet.
And so there's a range of people from stingers, football players who get their head and shoulder forced apart, or motorcycle accidents where people unfortunately land on their head and shoulder. And these are direct injuries to the brachial plexus, stretch injuries often, rather than what we see in thoracic outlet syndrome, which I love the way you described it as being an extrinsic problem that secondarily affects the plexus. Thank you, Tammy. Kai, I won't try to pronounce your last name. I probably wouldn't do it justice. How can I find the appropriate team of therapists and doctors in my area? I live in Cleveland. So first of all, I can say that we've directly interacted with TOS specialists in Cleveland. There was a fellow named Bernardo Martinez, I think, unfortunately, was retired now. You could try looking him up. St. Louis is not too far, and I happen to know an excellent TOS specialist in St. Louis right in front of us now. I will say this, contact us through our website. We'll give you names of people. Many people will do virtual consults to get started. I believe, Dr. Hagen, you will do those?
Yeah, we'll often do a telemedicine consult. And then, like you, if I know of somebody closer to them, and think you that have the diagnosis, we'll refer you to somebody closer to you geographically.
Excellent. Thank you. Thank you, Kai. Oh, Kai has more questions. That's good. I like that our viewers have lots of questions. They're very knowledgeable. Kai says, I've felt pain between my shoulder blade and arm. I've thought it might have something to do with the suprascapular nerve. Is this something that is seen in people with TOS? Excuse me. So Kai, if you want to send another comment in, I'm guessing you mean between the two shoulder blades, the interscapular region, or deep to the shoulder blade. But Rob, you deal with patients who have pain in these areas.
Yeah, again, the pain on the medial border of the scapula, like so the border of your scapula between the spine, if it's radiating down from your neck in along that middle border of the scapula, that's consistent with dorsal scapular nerve symptoms, which is part of the TOS or scaling triangle spectrum. If it's directly midline, your pain is directly midline, spinal and thoracic. I always say, obviously have your spine worked up, but also someone would want to check their aorta, because those are the two things that you worry about with true midline pain. But if it's off center along the medial border of the scapula, that can be dorsal scapular nerve.
Thank you. Thank you, Kai. Do you have any further comments or questions? Jackie O. I have TOS and I'm waiting for a scaling block. How will it help? How can I find out if I have TOS or a neck problem? All right, a lot of questions rolled into one. Scaling blocks have kind of an interesting history, and I will say personally, I've done them. I've seen the effects they have. I don't know why, and I don't think anybody so far has explained a very credible method of why a scaling block with either anesthetic or Botox makes TOS go away. There are some suggestions, but I haven't seen a consistent evidence-based reason for why that is. In the 70s in Los Angeles, there were docs who used this as an indicator to go to surgery. And I'll just say this, I think good imaging is a lot more valuable in making that kind of decision and helping a surgeon who does understand this area with detail. Rob, maybe I'm being just on my soapbox about scaling blocks, and you probably have a lot more experience than I do with them.
You know, we actually do use them for our workup, but it's because I do them myself personally. You know, I've been using ultrasound now for, probably 7 years. And what we've found out is that those patients who were seen earlier, right? So we're seeing some patients with these symptoms as early as 12 to 14 weeks after their injury. And that's the patient population where I would say, hey, we're really making some form of treatment, because it's not just a scaling block, it's a hydrodissection of the plexus. It's putting steroid into the scaling triangle, that potential space, hoping to break up inflammation and prevent scarring. So in some of those patients, I think we're obviating, that surgical pathway for them if we're seeing them sooner.
If I might interrupt, scaling block, to my understanding, the classic description of it is a needle within the substance of the anterior scaling and theoretically keeping the injectate within the anterior scaling. Is that?
Yeah, no, I think that's the classic. I agree. That's the classic description of it. But like in the spirit of what we've tried to do with all the things is to advance them and move them along. And I think just blocking just the scaling, it probably falls short of good clinical information. But when you block the whole plexus there, sometimes it's helpful in differentiating. Say somebody had we were trying to still differentiate.
Let me interrupt for a second. Explain to the viewers, when you're doing a hydrodissection, it's really a pretty different thing. Could you explain how you approach this and what your goal is?
Yeah, when we're hydrodissecting any nerve, particularly in the scale. So we think about it in the scaling triangle, it's the upper trunk, middle trunk, and lower trunk. You take a 1% lidocaine solution, and you're pushing that fluid between the plane of the nerve and the muscle that's usually kind of stuck down. And so if you can pop that plane open, you've kind of what we call hydrodissected it. You've put some fluid in there that pop that plane open. And then you can, if you have that halo, then you can put actually a little bit of steroid in that plane. And that's a therapeutic injection as much as anything. Is that a reasonable description for that?
Yeah, that's great, because I don't think people understand how close they are, but they're very different in the results. Yeah, I think my understanding of a classic scaling block for our viewers is use ultrasound or something similar to get the needle tip into the muscle itself, and you inject lidocaine, an anesthetic, sometimes Botox, into the muscle, but you don't want it to leak around and do what Dr. Hagen is doing. And by the way, just having read some papers recently, there's very little literature on hydrodissection. It's really good that you're helping to advance this. If you do a scaling block, you want it to stay within the scaling and theoretically relax the scaling. I've heard explanations that it allows the first rib to drop, and I don't know that there's much evidence for that or even the magnitude of that. And that has been used by some people to indicate going to surgery will be more successful. What Dr. Hagen does is a big step up from that, actually physically creating space around the nerve. If it is attached to the muscle by inflammation, you're allowing that to break up. And then Rob is injecting steroid to break the inflammatory cycle so it won't happen again. And as all our viewers know, nerves glide. They have to glide. They're in your fingertips, and your arm being all the way out and stretched is very different than it being close to your body. So what Dr. Hagen does is allows that nerve to potentially regain that smooth gliding. And I'll say one more thing here before I jump off my soapbox. TOS is not just compression of the nerves, but in many patients, we find evidence of tension on the nerves. Rob, I'm sure you do like upper limb neural tension tests or similar tests to look for that.
Yeah, it's a really important point. So important to understand that when that brachial plexus is kind of tethered, so to speak, there, I always talk about it being kind of like a finger trap, like or shrink wrap around that. And it tethers that nerve. And your point about the gliding surface is so important to understand. You have to reestablish the gliding surface and not just decompress it.
That's a great explanation. Thank you. Kai says, this is a great question. Have you worked with any professional musicians diagnosed with NTOS? So there is some literature on musicians. Rob, do you have much experience being in a big city working with musicians?
Yeah, we have a small series of cello players or violin players. That motion for somebody that I think is, or that position and motion for somebody that may be anatomically already predisposed to acquiring TOS is kind of the matchup, right? It's the double hit.
And they hold that position for hours on end to practice.
Yes.
Interesting story. There's a fellow I met outside of Boston, remotely so far, but he was a bass player years ago, a big upright double bass player. And having been a bass player myself, we hit it off. And he ended up having lots of symptoms that sound a lot like neurogenic TOS. And he went and became a therapist because he had such an interest in this. Very nice guy. He'll be speaking with us early this year.
Wow. Great story.
Yeah, he's a really good guy. All right. Let's see who has another question or comment here. Gail. Hi, Gail. It's a terrible way to start. My son nearly committed suicide. Doctors would test and refer repeatedly. A surgeon from out of state was found, and a rib removal gave my son back to us. Gail, as a parent, I feel so bad for you. It must be really tough to go through this, but I'm really glad to hear that he's doing better. If you'd like to share more with us, I'm sure all of our patients who have varying degrees of depression trying to deal with this would love to know that somebody dealt with it successfully, but they probably share your pain at having to go through it. So I'm glad he's doing better now. Thank you for sharing.
Scott, I think that's such an important part is we, as a peripheral nerve surgeon, I work with patients in pain all the time. And so often in diagnoses like neurogenic thoracic outlet, when that diagnosis doesn't get established early on and this prolongs over time, patients start to second guess their own sanity about whether they have pain or not. And they'll come and tell myself that they have doctors telling them that they're crazy. And they know their pain is real. I just had a lady, and it's often part of using the blocks is to help them understand that they do have pain too. So that's one concept of just in general peripheral nerve blocks. I had a lady I'll share with you within the past 6 months that we've gone through the whole treatment cycle, and she had neurogenic thoracic outlet on the left side for 13 years. And more recently, somebody shared that or told her that she had that diagnosis and was sent to us. We went through the workup. The when we do the blocks, many times there's tears of joy because there's a moment of them having actual pain relief. This and often they're crying. I've got a lump in my throat, borderline tears. I'm just it's very powerful for both the patient and the provider. But this lady, unlike other folks, as soon as her pain went away during the injection, she looked at me dead in the eye and says, "I'm not crazy. I'm not crazy." And it was validation that she had pain and that everybody had been telling her that there was no diagnosis of pain. So it's powerful how it can trigger depression or anxiety and change somebody's state of mind. So I think it's a huge, really important, close to my heart topic in these patients.
Thank you so much for emphasizing that. We get a lot of patients with a huge emotional component. That's totally understandable. Every day that I'm healthy, I'm thankful because we deal with these patients who really struggle. And it's just such a, I can't imagine how you felt when she said that to you. You must have felt like a little bit of a hero. You
Well,
know?
it was powerful because we often see that type of patient but nobody had that was it was the emphatic, the first thing she said as she was waving her arm in the air that she could barely move when she came in. So it's powerful and patients need to know that this is real to them.
That's why you spent all that time learning all this stuff in incredible detail. Make a difference in somebody's life like that is really an awesome little superpower. It's great. I remember years ago, I used to do spinal injections. And when we do epidural for some patients, they would get off the table gingerly and look almost confused at why it wasn't hurting. And nowhere to the magnitude of what you described, but it was really satisfying to be able to find an explanation. And we find that, as I'm sure you do, that when you give a name to the disease and patients can go research it, they can share it with their family, they look at it on Google, that's really powerful to help them find the strength.
Yeah, I would suggest that your experience with spinal patients, that any of us who've had a bout of low back pain know how humbling that pain is. And my guess is your experience was very similar with that patient population.
Well, you just have to be thankful that we can do these things to help people. How many people have the opportunity in their work to make a difference, like the woman you're talking about? Yeah, we're lucky. And all right, I'm going to go on to other questions before I get too sappy here. TOS Unbound, who's an exercise therapist and really asks great questions all the time. So I'm looking forward to this. And it is a good question. Do you see many similarities between the way we treat piriformis syndrome and thoracic outlet syndrome? Is one easier to address than the other? Both of them involve muscles compressing the nerves. So this is a great question. I know Tim in Las Vegas, one of your colleagues that I met through you, deals a lot with piriformis syndrome. What do you think about comparing these two syndromes?
I think they're very interesting. Tim's done a great job at championing piriformis syndrome. I think the reason why they're very similar to me is they kind of have 3 points that you have to kind of tease out. In piriformis syndrome, you have to differentiate lumbar spinal pathology from SI joint from true piriformis syndrome. And versus in the neck, a lot of times, or in TOS, you're often differentiating, cervical spine versus TOS versus shoulder pathology. I think it's easier to treat and differentiate the TOS symptoms than it is, peeling apart the SI, piriformis, and lumbar. We do those patients and we perform that surgery. I just think it's really, really hard to sift them out. And sometimes all three of the pathologies exist in the piriformis syndrome, SI joint, and lumbar pathology. So I don't know if that was a helpful explanation differentiating the two, but at the end of the day, it's similar pathologies.
So do you get piriformis syndrome in older people or younger people generally?
It's been a varying degree in my practice. Some are sport related, some are post hamstring tears, those kinds of patients I tend to see more. I think the older population, if they have it, when I've seen it, they have a split muscle, nerve goes through the muscle, or some other anatomic reason why they've presented with that.
So anatomically, there's some embryologic parallels between these sets of muscles. The scalenes are part of the body wall, and they actually develop as a sheet and they split up as the nerves pass through them embryologically. The piriform muscles, while you don't have the same dynamic component of the clavicle moving so much, they are intertwined with the nerves much in the way the scalenes are with the brachial plexus. So it's really interesting anatomically. There's a lot of variation there, which, the average radiologist, including me, I'd look at the piriformis muscles and, unless I really dove into it, I would just say they look normal and they probably have lots of variations to them, which can, as you said, you've got split muscles, can wrap around the nerves and cause same kind of issue. I think it's a great question. And actually, I was hoping to get to work with Tim a little bit on understanding more about piriformis syndrome and imaging it better. So we'll see how that shakes out. That's a great question. I really appreciate it. Thank you. Hi, Jackie. What imaging might be helpful instead of a scaling block? Well, first of all, there's lots of known variations to TOS. I always tell this story, but the guy who named TOS, a guy named R.M. Pete, he even acknowledged that in his paper in 1956. Say, look, there's a ton of these syndromes. They have different symptom complexes. They have different underlying pathologies. They have different provocative tests. It's just too confusing. Let's put it all together. Now, that doesn't really help when there's so much variability. There are, to my count, I think 26 different names for these syndromes that I could find in the literature. And I think imaging helps tease those apart. I don't think it's the same treatment for everybody, whether you go to surgery or not. And even if you do go to surgery, as Dr. Hagen knows, he goes in there and dissects in incredible detail, and there are differences between patients. So imaging is not going to show that you have pain. It doesn't do that any part of the body, but it does show what the underlying anatomy is. And in an area with a lot of variability, like the junction of the head and neck and shoulder, it's probably pretty important to know what's the cause of this neuropathy. Rob, do you want to add to that?
Well, I would just say, somebody with your expertise and the way you look at these studies is actually incredibly helpful. It takes your skill level to actually impact what we would do surgically. So I'm an absolute proponent of getting radiologic studies for sure.
And a scaling block is theoretically a functional physiologic thing, not even counting what you're doing, because there are very few people, if any, that do what you're doing with hydrodissection. But the scaling block by itself is kind of a functional physiologic test. It's got a different value, and I don't know what that value is by itself, honestly. Thank you for the question, Jackie. Hi, Samantha. Thank you, Dr. Werden and Dr. Hagen, for being here for all of us looking for answers. Is there any ongoing or long-term treatment you would recommend to achieve best results post-surgery for the patient? So, Rob, this is something where you clearly have more expertise than I.
Yeah, I think, one is, did we stratify surgery correctly for the individual? And then post-operatively, it's so important as usually that shoulder is in a position that is forward and down, internally rotated. And so PT in my mind is so important to get that shoulder back in a really good functional position. And people, there's a varying degrees of struggle about how you do that, whether your trap is really weak, whether you have trigger points in your trap or other muscles, whether your anterior chest wall is still really tight, all those things, whether you had some capsular adhesions because you weren't moving your shoulder joint. So post-surgery, PT is really, really important, I think, because you've got to get your shoulder back in the right position. And then, like any and all of us, you have to continue to fight your posture, because everything we all do is forward and down, right?
Good point. Yeah, if your head and neck and shoulders aren't in a good place, you got to shift everything to maintain a center of balance. Yeah. So Rob, do you have specific physical therapists you work with?
We do. We have select therapists that we identify, and then for those who are beyond the geographical, because we see patients from a large area, those therapists are committed to helping their local physical therapist, and that was just kind of the mission of building that team.
That is great. It's great. Another reason to see Dr. Hagen in St. Louis. What's it called? A plug. I'll keep plugging for you because I think you're great.
I'm just happy to be here, just talking about it with you. I mean, to the person's comment, just being available and helping people and providing awareness is really, really, really important.
Patients really appreciate having access to an expert like you for questions like this. So thank you for being here.
My honor.
I appreciate it. Okay. Is it Mikey Pearl? Hi, I'm listening from Patagonia, Chile. That's really cool. Thank you. I'm Kai's mom. He's a violin student in Cleveland. He was recently diagnosed with neurogenic TOS when he came to visit for the holidays. Thank you so much. Well, you know what? We can talk to people from anywhere in the world now. Thank God. I'm old enough to remember when long distance calls were so expensive that we could barely call our relatives in California when we lived in New York. And now we're really lucky. We're glad, if you have any questions, to consult us privately through our website. We can hook you up with experts like Dr. Hagen and others as you need, and hope that he's making progress and doing well. Thank you for watching. Hi, Tammy. Thanks for sharing, Gail. I'm so glad your son is better now. I think we all are. I can relate how he felt. Rob, exactly what you were talking about. There are days I want to cut my arm off from my shoulder. Yeah, you know what? This is our job here to try to help people get past this. And I'll just say I've been doing this for over 20 years. And for me, knowing that there are people like you, Rob, and other really good people out there who help patients, I also, thank my lucky stars that I don't have to deal with it myself. It's really hard on these people. So, Rob, the point you brought up before about the emotional component, it just adds to your value as you're not just a surgeon. Thank you for emphasizing that.
Thank you. I mean, I think to help this patient population, if you're not a person that has empathy, you probably won't truly understand how to help this patient population or anybody with peripheral nerve pain.
It's hard. It's hard on the patients, and it's hard on their caregivers. So, excuse me.
We walk through it with you, so to speak.
Yeah. You're a good man. Patrick, hi. Thank you yet again for spreading awareness of TOS, and he's flexing. So I hope you're feeling great today. Appreciate you being here. By the way, I didn't say at once, I didn't say throughout this talk, please subscribe if you're not subscribed. And after you subscribe, there's a bell. You can hit that icon and change how often we notify you. If you set that to notify for everything, that's helpful. Hit like as many times as you want. Rob, do you have social media that people can go and visit?
We do have a little bit. It's mostly our website and some blogs that go out into social media. I could probably it probably have a bigger impact if we did that. Every day I'm impressed with even some of our patients that go out and post things and stories and how many people they touch. So I'm a believer these days.
It's really powerful from our point of view. Yeah. And your website, if you want to tell people what it is.
Oh, it's just at neuropaxclinic.com. And Neuropax is something that we came up with. Neuro means nerve. Pax is PAX, which is Latin for peace. So nerve peace. And that's kind of the flag we fly to do our battle every day.
Excellent. Thanks, Patrick. All right. Well, we've gotten all our patient questions and comments. Again, I want to thank all the viewers for coming. Rob, your time is so valuable. I really appreciate you sharing with us. It's a pleasure to see you again and have your expertise contributing. Thanks so much.
Again, my honor. Happy to jump on here and help. Your cold sounds better, and hopefully you get some good rest.
Well, this is a good start to feeling better. I love these inspirational stories. So thanks a lot. I appreciate it. And I'll talk to you soon. For all our patients, thanks. Dr. Scott Werden, the TOS guy. Our website is tosmri.com. Dr. Hagen is at neuropax.com. Reach out to us if you want, because we'll connect you with Rob right away. Also, toseducation.org is run by, Herb Rep, and he does a great job at that. And you can learn about new videos that are coming out all the time. Jake, I forget his website. I will promote it again. I've just forgotten what it is for the moment, but he's a great kid and his family is great and his story is great. So thanks for everybody for participating, and we'll see you soon. Take care.